Hi all, today our focus is going to be on Chapter 7, Mood Disorders and Suicide. Very happy topics. So we're going to talk about characteristics of depressive disorders, characteristics of bipolar disorder, theories of depression, theories of bipolar disorder, treatment of mood disorders, and then we'll finish up on suicide. So what are some symptoms of depression? So we all feel down in the dumps sometimes, and we use the term colloquially depression. But depressed mood is really out of proportion to any cause. So this is when something, we all feel bad when something bad happens, and that's normal and that's human. But this is when the feelings of badness kind of extend above and beyond what would be expected to be normal and go on for longer periods of time. You also have anhedonia, which means loss of interest in everything in life. Like you no longer want to do anything, see anyone, you're no longer interested in your hobbies, things you used to enjoy. We also notice changes in appetite, so some people eat too much, some people eat too little, so you'll see people gaining a lot of weight or losing a lot of weight. People have trouble sleeping, they either sleep too much, you see people sleeping 14 hours a day. You also have people with severe insomnia, trouble falling asleep, waking up in the middle of the night, waking up too early, and they also have decreased activity levels and decreased levels of energy. We see psychomotor retardation or agitation, so people are slowed down, kind of like everything is in slow motion, or they fidget and can't sit still. Sometimes people in psychotic episodes of bipolar disorder can also lose touch with reality and experience delusions and hallucinations when they're very manic-y. So how do we diagnose depressive disorders? So for a major depressive disorder, the depressive symptoms that we talked about have to last 2 weeks or more and have to be present every day, almost all of the day. So then we can have major depressive disorder, single episode. So this is the first time that you've had it. There's not been a previous instance of depression. A major depressive disorder, recurrent episodes. There's a theory that once you've had one episode of depression, the likelihood and your threshold for having another one is lower, and therefore it's more likely that you'll become depressed in the future. Some people have what's called persistent depressive disorder. Used to be called dysthymia. It's depressed mood for most of the day for at least 2 years. So this is kind of what's been likened kind of to like an Eeyore. The people that are just a little ho-hum, gloomy, everything is kind of empty, you see the glass half empty instead of half full. So these are people that are functioning but are just kind of wet blankets all the time, and lasts for 2 years. Now in DSM-5 we have premenstrual dysphoric disorder, PMDD, which is an increase in distress during the premenstrual phase. This is basically PMS, which has now been pathologized. I have strong feelings against this, but the DSM has decided to make this a disorder. So if people experience symptoms of depression during the premenstrual phase, they now have a disorder called PMDD, or premenstrual dysphoric disorder. So there are different subtypes of major depressive episodes. There's anxious distress, where you see anxiety symptoms, mixed features where you have at least 3 of manic, hypomanic symptoms, but they don't meet criteria for a manic episode. You have depression with melancholic features, so these are people who have more distinct mood. They feel depressed more in the morning. They get up early in the morning, they have more psychomotor retardation, and you see significant weight loss and guilt. You have depression with psychotic features, so people who become very, very depressed can become psychotic. You may remember the case of Andrea Yates. She was a mother who killed her kids in Texas. She got so depressed that she started becoming psychotic and felt like that was kind of the right thing to do. You have depression with catatonic features, so this is kind of almost like, you probably heard of catatonia, where you don't really relate to the environment, you stop talking, you stop moving. Depression with atypical features, so these people still have reactivity, so they can feel better when good things happen. They have weight gain, increase in appetite, they're sleeping too much, their arms feel heavy or leaden, and there's long periods of sensitivity to interpersonal rejection, so they're very sensitive to the way others treat them. There's seasonal pattern, which is the seasonal affective disorder you may have heard of. It's a history of 2 years in which the major depressive episodes occur in one season of the year, which is usually the winter, and remit when the season is over. There's a lot of debate as to whether this seasonal affective disorder exists, but people say they feel better with those light boxes, and that it's due to the shorter days. Although if you look in places where there are shorter days, kind of like up north in the winter, there's not a disproportionate number of people who have seasonal affective disorder, so that can't necessarily be the cause. And there's peripartum onset, so this used to, probably you're familiar with postpartum depression. So it's the onset of major depressive episode during the pregnancy or at least 4 weeks following delivery. Again, there's debate as to whether this is really a separate disorder from depression, because if we look at women, typically they start experiencing these symptoms about midway through the pregnancy where they're having problems sleeping, and then it continues after the birth of the child where they continue to have problems sleeping. So there's some hypotheses that this is really, in addition obviously to your hormones being out of whack, that this is really a factor of just problematic sleeping and also the increased worry that comes along with being a parent and the mother of caring for an infant. So the prevalence and course of the depressive disorders, there's a high susceptibility in young adults because you're going through a phase where a lot of, there's instability in terms of your self-identity. You're trying to figure out who you are, and people can become depressed at this time. Their later depression is generally low among adults over 65 years of age and difficult to diagnose because a lot of, people attribute kind of being older and just being depressed as being natural, but that's not always the case. Older people are less likely to report symptoms, and usually the symptoms occur in the context of a serious medical illness, and so we don't look separately at the depression. And people with a history of depression are more likely to die before reaching old age, oftentimes because, the diet, the sleep, and all those things might be out of whack as well. Depression is less common among children, and women are more susceptible to depression than men are. It also might be that women experience depression differently than men. Can be long-lasting and recurrent for some people. Some people battle depression their whole lives. Depression is costly both to the individual, as it causes you problems with your daily functioning, working, etc., but also to society because of depression, a lot of people call out sick, and we have to pay a lot of money to have people on disability. People tend to recover with treatment, so that's the good news. So mania is part of bipolar disorder when people are in a manic phase. So there are two types of bipolar. Bipolar 1 disorder is when people have elevated, expansive, or irritable mood for more than 1 week, as well as the additional symptoms required to meet the diagnosis for bipolar disorder. Bipolar 2, you have a severe depression, but you have a hypomania, so the mania is not as severe as in bipolar 1 disorder. In cyclothymic disorder, you have both the depression and the mania, but both of them are less severe than in bipolar 1 disorder. So here's a table that contrasts bipolar 1 and bipolar 2. Bipolar 1, you can have depression, but you don't have to have it for diagnosis. Bipolar 2, you have to have depression for diagnosis. In order to meet criteria for bipolar 1, you have to have a diagnosis of mania, but you don't have full-blown 1 week of mania for bipolar 2. In hypomanic episodes, you can have those between episodes of severe mania, but it's not necessary for diagnosis. And bipolar 2, you have to have kind of a hypomanic episode for diagnosis. So symptoms of mania, rapid cycling bipolar 1 or bipolar 2, so that's when you have 4 or more episodes that meet criteria for manic, hypomanic, or major depressive episodes within 1 year. So that's when you're going from the high highs to the low lows, and it's happening multiple times a year. And you have disruptive mood dysregulation disorder, and that's when you have severe temporal outbursts that are grossly out of proportion in intensity and duration to the situation and inconsistent with developmental level. Like, for example, my 3-year-old right now, when he feels really upset, he gets really angry, but that's normal for a 3-year-old. But if you're a 30-year-old man and you're blowing up regularly, that's not acceptable, and it could be kind of the irritable component of the mania. Some people don't get manic in the sense that they have the fleeting thoughts or ideas running through their mind, but rather they get really irritable and argumentative, and that's when you see this kind of explosive disorder. So the prevalence and course of bipolar disorder, it's less common than depressive disorders. Women and men are equally susceptible. There's no consistent differences in prevalence among ethnic groups or across cultures. It develops mainly in late adolescence or early adulthood. And people who have bipolar disorder generally have problems on the job and in their relationship. And we'll talk about this, but there's a stronger biological component to bipolar disorder than to major depressive disorder. One thing that's been related to mood disorders, and especially bipolar disorder, is creativity. So when people are in a manic state, that's when they have the flight of ideas, they don't sleep so much, their mind is racing. People can have some benefits. For example, writers, artists, and composers have higher than normal prevalence rates of mania and depression. They feel like during these times they tend to be more creative. But mood disorders substantially impair thinking and productivity. So it's kind of like a mixed bag, right? Like they kind of like it, but at the same time it can be harmful to them. So some of the biological theories of depression, there's the genetic theory, which stipulates that genes predispose people to depression. There's a neurotransmitter theory where dysregulation of neurotransmitters and their receptors cause depression, and that's why we take medications. There's structural and functional brain abnormality theory that says that there are differences in the brain structure in those who have depression. We find altered brainwave activities can affect mood. There are neuroendocrine factors, so these are our hormones. That can also cause depression. So some of the psychological theories include the behavioral theory. So life stress leads to depression because it reduces positive reinforcers in a person's life. So if you have a lot of negative things going on, you can become depressed. We learned a little bit about learned helplessness theory. That was Seligman's theory with the dogs, where the dogs, they were getting shocked, and initially they'd be warned when the shock was coming, so they could jump to the other side of the box and avoid the shock. But then they no longer received the warning and the flashing light, and the shock was indiscriminate, and they just kind of gave up and didn't. They just got shocked and even they stopped even jumping from one side to the other. There are also cognitive theories of depression. These were postulated by Aaron Beck, Albert Ellis. This is where you have the negative cognitive triad. People have negative views about themselves, the world, and the future. So it's like they have these glasses on it where they see everything through a very negativistic perspective. And they kind of have reformulated the learned helplessness theory, and it shows how cognitive factors might influence whether a person becomes helpless and depressed following a negative event. So it's really your interpretation of the event in terms of how much you can control it or control your thoughts. They've also speculated that people who are depressed tend to have a ruminative response style, and you focus on the negative thoughts in the process of thinking, and that kind of contributes to depression. So psychological theories of depression, there's the interpersonal theory as well, and this stipulates that people become depressed because of losses in their lives that can cause the depression. It also can cause interpersonal conflict, because when people become depressed, they're not a joy to be around, and it often pushes away those around them. People become more sensitive to rejection, and they perceive it more often from other people, and especially when they are behaving this way, people are more likely to reject them, so they perceive this more harshly. There are sociocultural theories where there's cohort effects and historical changes put recent generations at a higher risk for depression due to unemployment, increased stress, longer working hours, etc. And that would somewhat explain the gender differences as well, because women are socialized differently than men, and there are different expectations for women than men. We also see different rates of depression across race and ethnicities. So in terms of the biological theories of bipolar disorder, there's a strong and consistent linkage in terms of genetic factors. As I told you, it runs in families, and if someone in your immediate family has bipolar disorder, there's an increased likelihood that you will have it as well. There's also differences in the structure and functioning of the amygdala in the brain, and abnormalities in white matter. We see a dysregulation of the dopamine system, and we also see people who have bipolar disorder have greater sensitivity to rewards. They experience stress more severely, and their routines are more frequently disrupted. Biological treatments involve taking medications, so selective serotonin reuptake inhibitors, SSRIs, selective seronorepinephrine reuptake inhibitors, if you can pronounce that word, it looked a little long for me, SNRIs, norepinephrine dopamine reuptake inhibitors, tricyclic antidepressants, monoamine oxidase inhibitors, MAOIs. So some of the typical ones that you probably heard about are Prozac, Effexor, those are the main ones. Mood stabilizers are used primarily for those that have bipolar disorder, so lithium and anticonvulsants, so anti-seizure medications, as well as atypical antipsychotic medications. The problem with lithium is that you have to have your blood taken regularly to make sure that the dosage is correct, and you can also overdose on it. People can also get ECT. Historically, ECT, if you ever saw One Flew Over the Cuckoo's Nest, was found to be people perceived it as a very negative thing. However, it still goes on even today. However, instead of doing it bilaterally, you only get shocked on one hemisphere of the brain. You also are completely put under, and you have a muscle relaxant, so you wouldn't even notice necessarily when somebody was being shocked, because there's no muscle movement. Now they don't know exactly why this works, but the only problem is there's some memory loss in the time surrounding the ECT, but it's not extensive. There's also one of the newer treatments, repeated transcranial magnetic stimulation. So they give you these magnetic pulses on your brain structure, so people actually have implants implanted. So these are for the most high-risk people that have severe depression. Nothing else has worked. Vagus nerve stimulation is also a small electronic device that's surgically implanted under the patient's skin in the left chest wall. And then the deep brain stimulation is also when electrodes are surgically implanted in specific areas of the brain. And I mentioned earlier the light therapy, so people who have seasonal affective disorder sometimes will use light boxes in the mornings to kind of stimulate the sun's rays, and they report that this helps them. So in terms of psychological treatments, we have behavior therapy, where you're increasing the positive reinforcers and decreasing aversive events, so having people go out and experience positive things, because when people come depressed, they stop going out at all, they stop showering, etc. You teach them new skills for managing interpersonal situations and the environment, so sometimes depression results from a skills deficit. And in cognitive behavior therapy, we aim to change negative and hopeless thinking patterns. So we identify these negative thoughts that are associated with depression, like I'm never going to do well, I'm not going to succeed, this is always going to go wrong. And we challenge that. We look at evidence to the contrary and work through that with the patient. We also help patients solve concrete problems in their lives and developing skills for being more effective in their world. So look, everybody's going to have problems, but every time you have a problem, you can't fall down on the ground. You have to learn how to cope with it effectively, and so working with the patients to solve some of those problems, learning different techniques so they can apply those in the future. In interpersonal theory, it's more based on the psychodynamic model, but it's still short term, and it focuses a lot on the grief reaction. And in part of interpersonal theory, you assign the patient a sick role. You say, right now you're dealing with depression, and it's like as if you're sick, and so you have to be gentle on yourself. Then you help them work through grief and loss issues, because those are often related to depression. So it could be the loss of a role in your life, could be the loss of a job, a relationship. You talk about interpersonal role disputes, and so you help them make decisions and communicate better with those around them, work through role transitions. So when they have roles that are lost, for example, if their children have gone away to college and they no longer perceive themselves as a mother, finding new roles and accepting the fact that their role will be different, and then teaching them skills deficits to overcome any interpersonal problems that they have. Interpersonal and social rhythm therapy and family-focused therapy are specifically designed for bipolar disorder. ISRT combines interpersonal therapy techniques with behavioral techniques and helps patients maintain regular routines of eating, sleeping, and activity, stability in personal relationships, which is really important because stress destabilizes people with bipolar disorder and can lead to a manic or depressive episode. So maintaining, healthy eating habits and a good routine is very helpful. And then family-focused therapy helps reduce the interpersonal stress that can occur in families of those who have bipolar disorder, and so it helps minimize that, so it helps them cope better. So comparison of treatments, there are different therapies are all effective in treatment. The combination of psychotherapy and drug treatment is more effective than either therapy alone. However, relapse rates in depression are high after any treatment. So you'll see here, Paxil is an antidepressant, so after 1 year, 45% of the people relapsed. Those who were in cognitive behavioral therapy, 30% relapsed, and those who took the placebo drug, 70% relapse. But the key here is that people who go to therapy have lower relapse rates, even though the outcomes are the same initially, because you're teaching them skills, and so they know how to prevent something from happening in the future. So now let's move to suicide. It's defined as the death from injury, poisoning, or suffocation where there's evidence the injury was self-inflicted. And the key thing here is the person has to have an intention to kill themselves. So it can't be that they were trying to cut themselves like a self-harm episode and then they accidentally killed themselves. The intent has to be to die. People who complete suicide obviously end in death. We have a lot of people who make suicide attempts which may or may not end in death. Surprisingly, I do research in suicide, and we have about between 10 and 14% of all John Jay students have reported that they have made a suicide attempt at some point in their lives. And the most recent data suggests that by the time they reach 18, 1 in 5 Latina females will make a suicide attempt, so that's 20%, which is very, very high. Suicidal ideation are suicidal thoughts or thoughts of wanting to die but not necessarily doing anything. There's evidence that up to half of us will have these types of thoughts at some point in our life, and currently about 25% of students at John Jay have some thoughts of wanting to end their lives. Doesn't mean that you're going to do it or that you have any active plan to do it, but that it's crossed your mind as a possible option. There's a possible addition related to the description of suicide in DSM-5, which highlights the characteristics to people that are vulnerable to suicide. And it describes suicidal patterns associated with a range of different diagnoses. So people who have depression, bipolar disorder, schizophrenia are more likely to, and borderline personality disorder are more likely to engage in suicidal behaviors. This encourages clinicians to attend to the suicide risk early and often in treatment, so that clinicians should be aware of these things. Suicidal behavior disorder and non-suicidal injury represent major problems on college campuses, as I discussed. Here we can see the rates of suicide by gender and age. So you'll see that as people age, there's increase actually in suicides. Especially the male rate of suicide is much higher than the female rate of suicide. Females make between 2 and 4 times more attempts as males, but males, when they do make an attempt, are much more successful, if you want to call that a success. Particularly vulnerable are older males, especially if they've been widowed and their health is declining. They often don't tell anybody, and they will make a fatal suicide attempt. There are ethnic and cross-cultural differences in suicide, and European Americans have higher suicide rates, followed by Native Americans. We're seeing that the rate among African American males has increased, which traditionally used to be quite low. We're now seeing very high rates of suicide in Europe, specifically in the former Soviet Union and China. And there are lower rates of suicide in Latin America and South America, and one hypothesis could be that these countries are still very Catholic, and that there's a belief in God and there's a prohibition against suicide. Here you can see the rates of suicide by country, and you'll see that the rates are highest in kind of the former Eastern Bloc countries, or countries that are having a lot of kind of economic or political turmoil. And then we're seeing lower rates in some of the more Central and South American countries, and some African countries as well. Suicide among children and adolescents, it's relatively rare in young children, but rates increase in early adolescence as kids start to go through puberty and experience changes and difficulties, and they're having trouble coping. Girls are more likely to attempt suicide, but boys are more likely to complete. And then, as I mentioned before, Hispanic females have high rates. Reasons that males are more likely to complete include substance abuse and the availability of firearms. Men will commit suicide more often by using guns, whereas women will use pills. And college students often feel intense pressure, but few seek treatment. And so you should all know that the College Counseling Center is free to use. It's on the ground floor of the new building. And the doors are always open. If you feel like you're distressed and you need to talk to somebody, you can go in there for a confidential appointment and talk to somebody. Among older adults, older men are at the highest risk for suicide, as we talked about before. It's highest in white European Americans over the age of 85 because of loss of losing their spouse and the pain and suffering of debilitating illness. I mentioned this earlier, but self-harm behavior or non-suicidal self-injury is when people generally cut or burn themselves. People usually do this in order to kind of feel alive or to mitigate emotional pain that they're feeling, but they can significantly injure themselves, but they don't necessarily have an intent to die, and it functions as a way of regulating the emotion or influencing the social environment. So you'll often see this behavior among prisoners if they're, for example, in solitary confinement. They'll cut themselves because then they know they'll have to go out and go to the infirmary because they can't stand being alone anymore. So historically, Durkheim was one of the first theorists to talk about suicide. He talked about the egoistic suicide, which was committed by people who feel alienated from others; anomic suicide, which was committed by those who experience severe disorientation from society; and altruistic suicide, which was committed by people who believe that taking their own life will benefit society in some way. These theories don't have a lot of empirical support, but we do know that social ties and integration into a society help prevent suicide. So things that can cause people to engage in suicidal behaviors are psychological disorders like depression, bipolar disorder, as well as people who have past suicidal thoughts and behaviors are at increased risk compared to somebody who hasn't. Stressful life events such as interpersonal violence and sexual abuse, loss of a loved one, financial hardships, and a physical illness. There is a concept known as suicide contagion, whereby suicide appears to happen in clusters. So once one person commits suicide, there are often multiple suicides around the same time frame. So these are suicides or attempted suicides, which are non-randomly bunched together in space or time and are likely to affect people who knew the person who committed suicide and are linked to the suicide by media exposure. The most famous of this was following, some of you may remember or may have heard of Kurt Cobain. He was lead singer of the group Nirvana, part of the grunge movement in Seattle. He committed suicide probably about, I don't know, almost 20 years now. And following his suicide, there were a lot of suicides across the country by kind of especially young men who are followers of his. So suicide contagion are suicide survivors who become suicidal and are modeling the behavior of the friend or admired celebrity who commits suicide. Other factors involved in suicide are personality and cognitive factors. People tend to be more impulsive, hopeless. In terms of biology, there is some genetic component to suicide, although it's unclear if this is really a genetic predisposition or people who have family members that have solved their problems through suicide learn this as a coping technique. We have found lower levels of serotonin among those people who make suicide attempts. So how do we treat somebody who is suicidal? If somebody is imminently suicidal, we'll take them to the hospital. There are also community-based crisis intervention programs which can work for people that are not acutely suicidal. People can get put on medication like lithium or SSRIs. There are also psychological treatments like dialectical behavior therapy or cognitive behavior therapy. In terms of prevention, so how do we get there? How do we stop people from making suicide attempts before it becomes too late? We have suicide hotlines that are anonymously available, and people can call and talk to somebody you don't know about your problems. There are crisis intervention centers where people can go. There are prevention programs based in schools and colleges which teach people coping skills and how to identify when they're at risk. But these have limitations because they target people in general and not necessarily high-risk individuals. It also can make suicide appear common. I don't know that this is necessarily a limitation. I don't know that actually completing suicide is not a common behavior, but many people actually have these thoughts and feelings, and many people engage in the behavior. So I think it's more common than people think. So most suicides that are completed involve a gun. So having a firearm at home is a risk factor. I'm actually very strongly against people having weapons in the home for precisely this reason. We had a young lady in our town who her boyfriend dumped her right before prom, and understandably she was upset, but her dad kept a gun in the house. She got the gun and she shot herself in the head and killed herself. Had that gun not been in the house, while she still would have been upset, she probably would be alive today. Restricting access to firearms lowers the chances of suicides because